Hi, and welcome to Hughes Knows Nursing. And I'm Professor Hughes, or Veronica Hughes, and today we're going to do a case study over metabolic acidosis. So, remember we've talked about respiratory acidosis and respiratory alkalosis. Metabolic causes of acid-base imbalances can be multifaceted, so, as we're going to talk about today. So it's not just necessarily the kidneys that are affected, but there can be different mechanisms at play that are leading to these acid-base imbalances. So let's talk about our friend Alex. Alex is 23. He comes to the clinic saying he feels bad. He's got fatigue, constant thirst, and frequent urination. So that's our little trifecta that should be cluing you into maybe what our friend Alex is experiencing. So fatigue, constant thirst, frequent urination. Okay. Focused assessment reveals rapid, deep respirations of 27 and a fruity breath odor. Any guesses yet as to maybe what our friend Alex is dealing with? Okay, this is going to give it away. A capillary blood glucose level of 475. So, super high blood sugar. We are probably looking at somebody with DKA, or diabetic ketoacidosis. So, it tells you in the name that it's an acidosis. So, our focus here is on the presentation of all of the things that walk like DKA and talk like DKA and smell like DKA and sound like DKA. So there's this like collection of symptoms that they present with, along with a medical history of just being diabetic. So, poor friend Alex, sorry. So what kind of acid-base imbalance are we experiencing? So in this case, it's going to be metabolic acidosis because it's a ketoacidosis that's causing our acidosis. Ketones are building up, right? So it's a breakdown of fats as energy because there's not enough insulin in somebody that's experiencing DKA. And so they can't utilize glucose for energy. So ketones are a byproduct acid of that fat breakdown. So the more you know. So yeah, he's not doing well right now. So he's got that deep respiratory rate, which is also called a Kussmaul respiration, which demonstrates that he's trying to compensate with his respiratory system. So he's doing those deep, right, in an effort to blow off some of that CO2. So there may be partial or full compensation just depending on what's going on with them. And it also depends on how long they've been hyperglycemic. So remember, the respiratory system can compensate way quicker than the metabolic system. So the chance of having compensation for somebody with DKA is higher. So what would Alex's ABGs look like? So with DKA, we're going to have, it's acidosis, so our pH is going to be below 7.35, right? We also expect that if we are experiencing some, well, let's talk about CO2 first. Actually, no, let's talk about bicarb. So our pH is going to be low. And remember, we have metabolic equal. As our pH goes down, our bicarb is going to go down. Okay, so if you remember that Rome mnemonic, respiratory opposite, metabolic equal, the pH in a metabolic acidosis is always going to trend down with the bicarb, or the HCO3. So they always go together. Then your PaCO2 could be normal if there's no compensation, or it could be low as well because I'm trying to lower my CO2 in an effort to dump some acid off because I'm acidotic and I don't want more acid, so I'm going to try to blow off some of that CO2, chunk some of that acidic CO2 out in an effort to bring my pH back up to a normal level. And the PaO2 should be normal. So treatment, what is our treatment for DKA? They need insulin, right? That's part of the underlying problem. They also need lots and lots of fluid and electrolytes to replace any losses that they have. They're going to get IV insulin. they'll get a bolus and then they'll be on some kind of drip, IV hydration. Yeah, depending on the level of acidosis involved would determine the degree of treatment. Okay, so metabolic acidosis. There's two main causes. You either have the accumulation of acids, so you're just dumping a bunch of acids into your system, like DKA, because of that fat metabolism. Another example is lactic acid accumulation, like you have in shock. So you'll draw lactic acid on somebody that you think might be septic. So the lactic acid is produced by the body trying to fuel the cells when it's under all this stress. You can also have not enough bicarb. So accumulation of acids, so we're just adding all this acid to our body, or we have a lack of bicarb, and the lack of bicarb is what's causing us to be acidotic. So an example of that would be severe diarrhea. I'm just dumping all of my bicarb through my diarrhea. Or if I've got some kind of kidney disease where my kidneys are not, they don't have the ability to reabsorb bicarb or secrete hydrogen ions. So remember, that's part of that compensation system with the kidneys, is they can hold on to bicarb and they can dump hydrogen ions. But if your kidneys are broken, they can't do that. Okay, so compensation, we mentioned a little bit about Kussmaul's respirations, deep and rapid in an effort to blow off all of that extra CO2 so we can get that pH down. Or our kidneys, if they're doing their jobs, can excrete acid. So hold on to bicarb, excrete acid. So, and remember with the metabolic ones, your compensation can happen quicker, which is handy. All right, that is it for our metabolic acidosis case study.